Let's talk about the neurologic system of children. So, when it comes to the brain, the meninges, a lot of this stuff is exactly the same, so I'm not going to go into that. It is important to note that the head circumference will increase over time and peaking at about like 5 to 8 years old. So that's one of the reasons why we have to keep measuring the head circumference. We have to compare it to the growth chart, right? Make sure that it kind of follows the curve that we would expect it to follow. Myelination will proceed in the cephalocaudal direction. And that's one of the reasons why we really want to check newborn reflexes. We're going to be looking at cerebral palsy specifically, and how cerebral palsy can often first be detected just by newborn reflexes persisting longer than they should. Cerebral blood flow is maintained through autoregulation. Remember that? So if your brain is not getting enough perfusion, it's very likely to assume that the rest of your body is not as well, right? There's probably something going on where the brain is trying its best to get as much blood as possible, but for some reason it's not doing it. Right, basic diagnostic tests. I don't feel like I need to go into those. When it comes to altered states of consciousness, don't really waste time on this. If you already know what a lethargic person looks like, if you know someone who's in a coma looks like, if you know what a confused person looks like, that's fine, right? I'm not going to be super specific about like the details of this slide. Just be familiar with the terms. All right. Altered states of consciousness. Obviously, there's a lot of different things that can cause altered states of consciousness. Unfortunately, this is a common problem in the emergency room. Somebody comes in and they're just like, they look really sleepy, and you can only get them to respond by kind of shaking them around a little bit. And there's so many different questions that run through your mind. If you're a triage nurse and you're trying to think of like, all right, what are the million different things I know that can cause this response, right? Does he have some kind of disease? Is there some kind of medication he's taking? Is he high on whatever is he high on opiates? Does he just smoke too much weed this time? Like what is it, right? Does he have some kind of electrolyte disorder? Has he drank too much alcohol? Does he have some kind of metabolic problem that he should be treating but isn't? There's a lot of different things, right? So that's just the point of this list, to kind of summarize those for you. Remember that CPP is a measure of MAP and ICP, right? So if your intracranial pressure goes up, your CPP will go down, right? Because you're subtracting. In this case, you may want to keep your mean arterial pressure up. Even if the child has hypertension, if you treat that hypertension and take it away, then that will also contribute into dropping your CPP, right? So let's be aware of this relationship between MAP and ICP. That'll help you, especially in adults, actually. I've seen it more often where, like permissive hypertension for people who they're worried about increasing intracranial pressure. All right, altered states of consciousness. They often follow a very predictable sequence. From my experience, so the state that I've seen most in practice, but also in like test questions, is an irritableness, right? So if a child is really restless and irritable, of course it could be a lot of things, right? It might be that their diaper is wet and they just want it changed, and the parents aren't changing it often enough. They have a diaper rash. But you have to at least have it tucked in the back of your head, like altered states of consciousness. Maybe there's something going on. So as the brain starts lacking perfusion, the first thing you'll generally notice is that the child just seems irritable. Then they'll start getting drowsy. Then they'll just get so drowsy that they actually become lethargic. They need a lot of stimulation to stay awake, and then they go into these involuntary posturing. Then they dip into Cushing triad. Cushing triad, something you should have seen in the adult world. If you're not familiar with it, either memorize it here or just go back to your previous textbooks and relearn that, because that is very important. And there's some more science in table 27.4 that are listed right here. So Infants have some very specific signs like irritability, right? With the bulging fontanelle, obviously, but also this high-pitched cry. This high-pitched cry is unique. And if you're listening to an infant and you're wondering, like, is this a high-pitched cry or not? It's probably not a high-pitched cry. You'll probably recognize it when you hear it. It is pretty distinct, so maybe you will need to learn it a little bit. But once you learn it and once you identify it, it's pretty easy to detect. Like, wow, that's a really high-pitched cry. That's not normal. We should do something about that. Some early signs right here, late signs right here. Of course, the Cushing triad is very much a late sign, but more things are listed right there. All right, different tests that we want to do are listed here. I feel like they're fairly self-explanatory. Your Glasgow Coma Scale. So your Glasgow Coma Scale has there's a pediatric version of it that you should be able to use it, but I don't need you to memorize it. I'm not going to say, hey, they can open their eyes to sound, they can cry to pain, and they can withdraw to pain. What GCS score are they? I'm not going to ask you that on a test, but you should be able to know how to use the scale, and you should be able to figure out, or you should have some kind of familiarity with how this progresses, the progression from 5 to 1, especially for the verbal response, and then motor response, right? Now the decorticate posturing is a little bit better. I mean, it's bad, but it's better than the cerebral posturing, but it's not as good as just withdrawing to pain, you know. So you should be able to understand this progression from the best finding to the worst. So there's also AVPU that's shown on these tables right here. If you're doing a super quick assessment, either maybe you forgot this scale, you don't have one on you, you're just giving like a super quick report, you may want to just stick to the AVPU. So A is they're alert, so that's normal. V, so they can respond to some kind of verbal command, right? P, they can't respond to verbal command, but they respond to pain. U, they're totally unresponsive, right? Super easy. Anyone can do this, right? And everyone understands how this works. GCS is a little bit more accurate. It'll give you a little bit more information, but in a pinch, AVPU will help you out. So when it comes to altered states of consciousness, the more sensory stimulation from the family, generally the better, right? If they're touching them, stroking them, like talking to them, showing, having tapes of them if they can't physically be there. All of that is only going to help the child. So at the very least, it's not going to hurt them, right? It may not help them in the sense that, yeah, I guess if they're in a complete coma, I mean, there's no brain activity going on, right? They're not really hearing it. But at the same time, you don't know when they're going to come back to a more higher state of consciousness. And the more things we have at that crucial point where they're starting to regain consciousness, the more oriented they can be, the much better off they'll be, the better recovery that they'll make. So be very specific with parents, especially in the ICU. Like, don't just make sure you stay away from this. Make sure you stay away from this, but you can touch them. You can help me in some skincare. You can help me with positioning a little bit, and then often that's the trick to get them to feel comfortable around the bedside and to be involved in the child's recovery. All right, seizure disorder. So it's some kind of excessive activity in your neurons. It's part of the reason why this is a pediatric problem is because the highest rate of onset occurs in the first 12 months of life. So we really need to be watching out for this. It can happen for all sorts of different causes, as seen there. Many seizures don't really even have a known cause, which just kind of happens. Status epilepticus is kind of a technical term that we need to know, right? And you can be deemed in status epilepticus in two ways. Either it's prolonged, like one really prolonged seizure, or there's no full recovery from the seizure before the next seizure, and that lasts for a certain amount of time. This we say 15 minutes. We're gonna go off of that. In others, I've seen 30 and 10. So the threshold does change from what I've seen, but I think most people agree 15. Remember that seizures use up a lot of sugar, a lot of oxygen, so you gotta be mindful of that, right? Maybe we need to replenish their sugar, their oxygen, especially if they've been seizing for a long, long time. We gotta look out for that. So some of this stuff is pretty similar to what you've already seen, right? You know what a partial seizure looks like. You know what a generalized seizure looks like, right? For generalized seizure, there is a strong familial incidence, so that is something worth noting for our purposes, that if a child has a family history of it, then we will be very cautious with the children, and we'll be looking for it. If you need review on the manifestations of these different types of seizures, definitely look at that. Childhood absence epilepsy. There's a genetic predisposition to this, and if you see videos of it, then you'll know what it is, right? They have this weird. They just snap into it. There's no aura, no way to prevent it. It just happens all of a sudden. You can't. During the seizure, you can't break it by touching them or calling out to their name. Then all of a sudden they come back. They don't even know that they've had a seizure, right? So the onset is around 4 to 10 years old, and the remission is in adolescence. So in that sense, it's very much like a pediatric thing. You may develop other seizures, but not necessarily. Some children just do just fine with no noticeable long-term sequelae. So hopefully that's the best case scenario. It just kind of goes away by adolescence, and then we never hear from it again. Juvenile myoclonic epilepsy is a genetic disorder. So if they have a family history of that, make sure you're watching for these quick involuntary muscle jerks, and especially during puberty when it peaks. Infantile spasms. So infantile spasms obviously happens mainly during infancy, and this is really abrupt spasms, as you might expect, right, from the name. And it's the thing about newborns is that they have a lot of weird movements. I wish all infantile spasms did these head nods or these jackknife body contractions, if only because I could be able to notice them very easily. Parents would also notice them very easily. A lot of times infants just kind of move weird. There's no really explanation for why they move that way, but it's up to a lot of different factors in terms of how aggressive we want to be in terms of detecting a seizure and trying to treat it, right? The good news is that it'll stop by about 5 years of age. The bad news is that there will be developmental delays, which will likely reach beyond 5 years, right, and may affect them permanently. So we want to make sure we're treating that. Like I said, neonatal seizures are weird. Sometimes they can look like any of these things, so you should be able to at least generally describe what a neonatal seizure might look like and identify it, right? If they're doing any kind of rhythmic movement, like leg pedaling, like they're riding a bicycle, or they're swimming movements, or it might look like they're boxing, like they're fighting someone, or if they're apneic, then you should definitely consider some kind of seizure. Seizure disorder, the history is so important. When was it? When did it happen? Was there anything happening before, immediately before, like a trauma? Was there a recent head trauma? How long did it go for? What kind of activity? So specifically, was it similar to previous seizures, right, if they've had them? Color change will generally start at the lips and to the, like around the mouth, circummoral cyanosis, and then you have like around the face and maybe even all the way to the body. So you want to know exactly what color changed and how far it went, right? If they're similar to previous seizures, like I said, are they taking their medications? Is there any kind of new thing that they've taken? Maybe they supposed to be on seizure medications and they drank alcohol and the alcohol interfered with the medications, things like that. So when you're trying to treat seizure disorders, first we want to get a good, get really good testing done, right? So very important to do CBC CBC is everyone, right? Lumbar puncture for if there's any kind of concern for um, meningitis, right? Um, or maybe just increase intracranial pressure so you can measure the CSF directly. So there's actually a really good book, The Spirit Catches You and You Fall Down. It's a book about a small girl who had seizures, and she had seizures all her life, basically. And the seizure that really, really, really wrecked her and pretty much left her brain dead, um, everybody was so focused on the fact that she already had a seizure disorder, nobody bothered to check whether she might have had an infection as well. All the signs were there, all the labs showed infection, but people weren't thinking that. They were just thinking about her usual seizure medications. And so by the time they checked her temperature, which was way later, way after they did all the different things that they did to stabilize her and to stop her seizures, they realized, oh, she has like a raging infection, and that infection left her brain dead, right? So, I mean, that it definitely happens, right? You get kind of tunnel visioned into thinking that the seizure is probably coming from epilepsy, but you're always gotta be considerate that it could be. You got to do your culture CBC and keep an open mind, right? That book is also talks a lot about medication levels. Those parents, the parents of the child, at times refuse to give the child seizure medications, and so they would draw medication levels, and they would be really low, and because the parents weren't giving them. So you may run into that. More likely, you'll run into just maybe there is evidence that the child is taking all the medications, but there is evidence that maybe something is interfering with the medications. Maybe they're eating some kind of fruit or some kind of other food. Maybe they're taking another medication that's inactivating the seizure medication. Maybe they're just growing. Maybe they just need a higher dose to get the therapeutic level in their blood, right? So a lot of different reasons why to draw medication levels. If they're a newborn infant, definitely want to do inborn metabolism tests. There are a lot of different things that we screen for early on, like we talked about last time about phenylketonuria and all that. But those tests aren't 100% perfect, right? If you're stumped, then you may want to revisit those. Urine tox to look for any drugs that the child might be taking or might be exposed to. Of course, imaging to look for like brain bleeds, tumors, and all that stuff, and EEG. So you can see the EEG right here. You got all this stuff hooked up to their head, and you got this stuff on the monitor here. A lot of times you'll see, or if you're on the neuro unit for any amount of time, you'll see these children who have this where they're deliberately trying to induce a seizure because they want to see where the seizure is coming from, right? They want to see the activity while they're attached to the EEG. So you'll see children being kept up all night to try to force them to have a seizure, which is kind of weird, but you will see that. So many people require no treatment at all. Many children who have seizures, you just kind of wait and see. Hopefully it never comes back, right? Especially for like an absent seizure, you don't necessarily want to treat that if the absent seizures aren't very frequent and if they're not really affecting them in any way, right? And if it goes away, then it goes away. Then we're good. We never had to initiate any kind of seizure medications. Remember, we're always doing our ABCs. ABCs always come first. And then, of course, we're trying to stop the seizure and trying to treat anything that might have caused it, right? Of course, get glucose and blood gas levels afterward to measure, make sure that they're not hypoglycemic. Maybe the hypoglycemia caused the seizure, or maybe they got hypoglycemic because of the seizure. Either way, we want to get a sugar level, and we want to get a blood gas to make sure that they've been oxygenating well. So, when it comes to medications, you want to go from least invasive to most invasive, right? So, least invasive is to just give one medication. Then the next most invasive thing is like several drugs, right? The problem is that these drugs have a lot of side effects, right? Like depression, suicidal thinking, learning deficits. The less medications we have, the more we can at least just kind of adjust it as needed. there's a lot of driving restrictions, unfortunately. So for these kids, because I mean, I'm sure that most kids want to drive ASAP, right? So this can be an issue when it comes to the specific restrictions. They differ state by state, right? Definitely, the states want to give people the liberty to drive if they can, but if you have a seizure disorder, it might not be the best interest for other people and for the child with the seizure to be driving around, right? It's very dangerous for everyone. So want to be mindful of that and try to do our best to treat it appropriately. Definitely avoid alcohol. It's a huge thing. Alcohol interferes with all the different seizure drugs. And that's a problem because seizure drugs, you have to eat them, you have to take them every single day, right? There's never a day where you're not taking the seizure medications and then alcohol drinking is okay. Most of these drugs, a lot of these drugs, these children are on it for life, and you're pretty much telling them you can never drink alcohol ever again, which is a tough sell for a lot of older adolescents who are in that kind of rebellious phase. They want to drink some alcohol. So this medication list was taken from your textbook. I reorganized a little bit to follow the pattern that I generally see, either in the hospital that I work in, or just from different doctors that I've seen, or listening to like podcasts and stuff like that from ER doctors. And this is generally the pattern they follow. So for sure, your hospital is going to have one of these medications in the Pyxis that you can't override, diazepam or lorazepam. And generally it'll be lorazepam from what I've seen, aka Ativan, that is used to break seizures in the hospital. The diazepam is nice because it comes in a rectal formation, and so parents can give that at home. But in general, if a child starts seizing in your hospital and the docs want to treat it, they'll see like, oh, let me get Ativan in here. Let's override it from the Pyxis. So you just go into the Pyxis, override Ativan, you pull it out. And definitely, like in this situation right here, that is a time when you definitely want to know the dosage for your Ativan, right? And to do the medication either in your head or very quickly on paper, right? Because you're not going to get an order, you're not going to get all the pharmacy verification and all that, and you may not even have a patient's weight, right? So you got to work with all that. So phosphenitoin is also a popular one. Keppra, phenobarb, Depakote, so valproic acid. So you'll see this kind of move in this direction, right? Starting with your benzo, there's some benzos like diazepam, lorazepam, and then moving down. A lot of them have very similar side effects like respiratory depression and sedation. So just be mindful of that. I do see these other ones, but for the sake of focusing our studying, I'm not going to talk about Onfi, Trileptal, Topamax, Lamictal, Felbamate. I see all of these things, but I tried to pick the ones that are one, most often used, and two, most often specifically most often used during emergencies, because that's really where you'll need to know some of this stuff off the top of your head, right? As opposed to some of these other medications where if you're just kind of like giving a prescription for it, you have time to look up the information. So that's my, at least my reasoning for why I chose some medications, not others. So either we want to, a lot of times when we're giving medications, even despite the medications, we're still having seizures, and we want to think about other things, right? Vagal nerve stimulator is obviously pretty invasive. That's something to consider. Basically, it just stimulates the vagal nerve, right? And it can be controlled by a magnet, and you can trigger it after an onset of an aura. So this is something that you might want to consider. There's also a ketogenic diet. It's very important to know that you have to cut out all glucose, right? So you see here, almost half of children have 50% reduction. So it's not that great, right? It's just very few of these have like complete reduction of seizures, but half of children, 50% of seizures, and this is for a diet that has very few side effects compared to your medications, right? So maybe a parent can live with that. Maybe the parent and child decide like, hey, I like this. I like not being on medications. I like just having it in a diet form, or maybe they have their medications on top of the ketogenic diet. There's a lot of different options. So ketogenic diet is one of those things to consider as well. When it comes to seizure medications, in terms of which ones will work, how much to give, there are a lot of rules to follow, but a lot of times it's trial and error. And that's particularly important when you're trying to withdraw the medications, right? So sometimes the provider will deliberately withdraw medications, just wait for seizures to happen, and if they don't, then we know that they can go on a lower dose, right? The only way they can really know is by doing this trial and error process. So a rule of thumb is 2 years. If you have 2 years of no seizures on your current medication regimen, then that's a pretty good reason to consider pulling back. So you don't need to know all the specific side effects except for the ones I listed on that table, and then just know that in general they cause this kinds of stuff. There's depression, anxiety, behavior problems, ADHD. A lot of these like psychological problems can be a result of the medication they're taking. So, there's a survey that they did, questionnaire, about what's the worst thing about having epilepsy. And it may surprise you that children say that 50% that they say that the worst feeling about having epilepsy, the very worst feeling, is feeling different or being teased, right? And only 38% the actual physical act of the seizure, right? So the feeling of feeling different or being teased is more of an issue to them than the actual physical act of the seizure itself. So we have to be mindful of that, and just to help kids deal with this. I already talked about alcohol and adherence, the problems with that. Safety measures, very, very important. Of course, no open flames. They may need a helmet, hopefully not, so they don't feel so different, right? This does not help in terms of getting teased, usually. So, and of course, medical alert identification. I already talked about driving restrictions, so I'm going to go past that. All right, febrile seizures. So if you want to call a seizure a febrile seizure, it has to fulfill several criteria. First criterion is has to be in the first 24 hours of illness, has to be age appropriate, right? About 9 months to 5 years old. But it can be seen a little younger as well, a little older as well. It has to be less than 15 minutes. And it has to look generally like this, right? And it shouldn't, the child shouldn't already have some kind of seizure condition. So if they fulfill all those, then you can call it a simple febrile seizure. And the good thing about simple febrile seizures is that the vast majority of them are not treated at all, right? You give some antipyretics and you give some education. And that's pretty much it. Part of the education that we're giving them is the fact that we can't prevent the next febrile seizure if the child has one, right? A lot of parents get really aggressive with the Tylenol and Motrin. They figure, hey, if I just keep blasting them with these antipyretics, we can treat all seizures in the future. And there's a couple of things that you can say to that. Like, one, why even bother preventing simple febrile seizures, right? They don't harm the child, and they don't increase the risk of epilepsy later on in life. It's not really a big deal. But of course, parents don't like hearing that, right? They don't want you to say that there's no hope in preventing it, and that there's no harm in it, because definitely it scares them, and it is very distressing, right? But we do want them to know, hey, you can't prevent it, right? All you can do is keep them safe the next time it happens. And one thing to know is that the febrile seizure has to do with is thought to be the quick rise in temperature. So usually if they're already at a high temperature, that's not really the problem. It's suddenly going from non-febrile to suddenly very febrile. That very first spike in the fever, that's usually what causes the seizure. If it is not in the first 24 hours of illness, or if it lasts more than 15 minutes, or if it doesn't look like this generalized tonic-clonic movements, then it is complex febrile seizures. So these complex febrile seizures are very different. It's a greater risk in developing epilepsy, and so you may want to treat that, right? Also, if it recurs within 24 hours. So that's a reason to call it a complex febrile seizure as opposed to a simple febrile seizure. So we have to definitely know the criteria of simple febrile seizures. Bacterial meningitis. So bacterial meningitis obviously is seen in adults as well, but you won't see bacterial meningitis in adults really that are secondary to things like otitis media, sinusitis, pharyngitis, right? You don't think of adults who have like the common cold as suddenly getting bacterial meningitis, right? Something that generally happens to neonates, children who just have very poor immune systems in general. And so, obviously, they're gonna have like this bulging fontanelle. They'll be in this epistotonic position because they have their meninges kind of along their back right here, right? And they want to relax it as much as possible. And the position that this kid is in right here, with their back kind of curved that way, that is called the epistotonic position. Because their meninges are irritated, they want to assume this position. So we don't want to force them to bend, right? We don't try to get them out of the epistotonic position. If that's how they're comfortable, leave them that way, right? If anything, with bacterial meningitis, we want to reduce stimuli as much as possible. We'll dim the lights. We'll make it nice and quiet. We'll take away any other stimuli that can possibly be happening. Just try to calm them down as much as possible. Any kind of crying is going to increase the intracranial pressure, and that's not good, right? They already got this bulging fontanelle, and we don't want to increase the pressure anymore. Actually, with the meninges being irritated, you might see babies who are being held by their mothers and being rocked and swayed, and that might make them cry. Whereas up until then, rocking the baby, cradling them, swaddling them, like then shaking them, helped them and soothed them. Now it's irritating the meninges. They may cry, and sometimes when you put them down, then they're fine again, right? So because they're not getting their meninges irritated anymore. So that might be a sign of bacterial meningitis as well. In older children, bacterial meningitis signs are very, very similar, right? This nuchorigidity, the cardiac persistence, the petechiae, the confusion, right? So hopefully you guys remember bacterial meningitis in adults, and if not, then just kind of review it really quick. And here's the cardiac persistence scans being done. Basically, you just have to know that it's causing irritation to the meninges, and we're deliberately causing the irritation and forcing them to react to that, so that we can test for meningitis. Alright, so in treating bacterial meningitis, of course, we want to check our blood counts and cultures, both of blood and for CSF. We want to check electrolytes. Of course, all these other things as well to check for, especially if they're getting like septic and going to DIC or something. Definitely got a lumbar puncture. And when you think of glucose is very important because bacteria love glucose, right? So if we get the CSF and we measure the glucose on it and it's low, they may even actually ask you to do a point of care test on the CSF. And if it's low, then we know that it's bacterial, right? Of course, we will get other signs of bacterial meningitis from these other things as well, even just from their general symptoms, but glucose is one of those things that you have to know. Antibiotics, ampicillin, ceftriaxone, or cefpime that I've seen. All these things can be used in bacterial meningitis treatment, and these are all very broad spectrum, and if the cultures come back negative, then we might stop it. If the cultures come back specific for something, for a specific bacteria that's better treated by something else, then we may change those antibiotics. But giving AMP and some kind of late generation cephalosporin is what you'll generally see. So with bacterial meningitis, Let's see. So I mentioned disseminated intravascular coagulation, DIC, but don't worry about the details of that. We'll learn about that later in week 7. There's cerebral edema. Hearing loss, unfortunately, is common just because of the way it damages your brain. And vaccinations are, of course, important because some of the things that cause bacterial meningitis are preventable via vaccines. If we do all our cultures and everything like that, and they all come back negative, and the child doesn't look quite as sick as we would expect with bacterial meningitis, then we can be pretty sure that's viral meningitis, and we just give supportive care like usual, and then they just go home, nice and easy. Encephalitis is a little different, where it is also caused by a virus crossing the blood-brain barrier, but you get these different signs. You get this severe headache, bulging fontanelle, ultimate status, meningeal irritation, and it might be something from like West Nile. So ask about travel to places like insect bites. You may want to do an ELISA test. So you guys might know with like blood cultures, it's nice and easy to get. It's relatively easy to get a blood culture, right? You get like the blood culture bottle, and then you just drop a little bit of blood into there, and then basically we just wait a few days, and then we use a microscope to look inside, right? And if we find bacteria there, then there's enough of it that we can actually look at the bacteria and you can tell us what it is. The viral tests are a lot harder. You have to test for viruses one at a time, and you have to do things like ELISA tests. So generally we don't have to do it because most viruses just go away on its own, but if you're worried about encephalitis, then you definitely will want to. Reye syndrome. So Reye syndrome is one of those things, right? If you see aspirin and children in a question, the answer is Reye syndrome, right? You should automatically be thinking that direction. For my purposes, there's only 35 cases a year in the United States. That's incredibly rare, right? There's not even one per state. So I am going to probably correctly assume that very few, if any, of the people in my pediatric classes are ever going to see Reye syndrome. So I just know the basics, which is what NCLEX will constantly pound into your head, which is the no aspirin for children, and then you should be good to go. You should know that it affects the liver, but it's not just the liver, it's like actually a multi-organ thing. It's very very bad for children, and all we can really do is the supportive care. Guillain-Barré syndrome. So Guillain-Barré syndrome is actually rare in children compared to adults. They may complain about ataxia because it's paralysis from feet on up, right? So this is actually like the classic presentation, like description of it. Anytime you hear about paralysis going from the feet and gradually going up, you have to be thinking about Guillain-Barré syndrome. And Guillain-Barré is one of those things that's not well understood. It's something where our body is doing it to ourselves, and of course, anything like that we generally treat with something like IVIG, right? So as the process goes on up, I mean, at first you might get ataxia, right? That's not great, but at least it's not something like life-threatening, right? But as the paralysis moves up, and once you start seeing symptoms as high as like the throat and like the face, then you're really in trouble because there could be respiratory failure coming once that diaphragm becomes paralyzed as well. All right, headaches. So a lot of children experience a headache by 15 years old, right? Most kids, and a lot of them have these migraines, right? Hopefully, you guys have seen enough migraine like medication advertisements that you know what it looks like and know what it's triggered by. You probably have some experience with it yourself or with like a friend or family member. But it's triggered by any of these things, right? Stress, food, nitrates, glutamate, caffeine. A lot of children with migraines, a lot of times they know that they have migraines, right? They know what their triggers are. They know their symptoms. They know their aura. So a lot of times you're using that information to treat it, and that's nice, right? When they know exactly what they want and what they're going through. If you spend any time in the ER at Chalk, there's a good chance that you will at least run into a couple people with migraine headaches, and then we give them the migraine cocktail: bolus of fluid, some Toradol, some Compazine, IV Benadryl. Give them a little time to rest, give them a little sleep, lower down the lights, and usually that's pretty good, right? If you have migraine in your family, then there's a good chance that you have it too, unfortunately. There's a genetic component to it. So tension headaches and medication overuse headaches. We're actually going to talk about that, I think, in a couple slides. So, but basically, tension headaches related to like stress, generally related to stress, school, fasting, and inadequate sleep. Medication overuse and rebound headaches, as you might expect, is from medication overuse. Especially NSAIDs, right? A lot of people just take NSAIDs all day for their headache, and they don't realize that they can have rebound headaches as well, right? So definitely want to prevent that. Even though NSAIDs generally don't have side effects, they do have some side effects, right? It's not completely 100% benign, and people should know that. Of course, detailed history is very, very important. So we can know what's going on. And we want to make sure that there's no other neurologic signs that we should be worried about. Headaches, obviously, are relatively benign. Like, people get headaches, and not everyone gets a CT or MRI, right? Especially children, for whom sometimes an MRI would require sedation. That's not good, right? So MRI, you might think, like, oh, it's just magnets, at least it's not radiation. Yeah, but they may be at risk just because of sedation that's required, right? CT scans obviously have a bunch of radiation, so we don't want to do that unless we really need to. Okay, so there's a lot of behavioral things, a lot of environmental things that you can try to help with headaches. Try to avoid the things that trigger it, right? One of the things that might help is a headache diary. Headache diary does a couple things. One, it might help you identify triggers, and might help you to think about when you get them, and how you can think about the headaches in relationship to the things that you eat, the things that you do, to figure out how you can reduce the number of headaches. Also, if you eventually the headaches are so severe, so frequent that they send you to a neurologist, they will often have you start a headache diary. If you already have one and you can just hand it to them, then that's great, right? You get a nice heads up, you get a nice head start in terms of your relationship with your neurologist. They can look through it and figure out where to go from there based on the details that you've written down. All right, migraines. So I talked about migraines. So one of the things that might distinguish it is like this pulsatile. So if it's pulsatile, then definitely start be thinking migraines. If they have photophobia too, right? There's actually not many visual disturbances with something like tension. So in these ways, you might want to distinguish between like migraine or tension headaches. Tension and rebound headaches are often very similar, like a pressure or like crushing. And one of the ways to distinguish it is like if it's less than 15 days a month, then think tension. If it's over 15 days a month, think rebound. And especially if, of course, they're using a bunch of medication, then it's the open shut case. Of course, if there's any kind of inflammation going on in your brain that's causing pain, then you may have a fever as well, on top of the headache. So when it comes to structural problems, right, these are like space-occupying lesions, very likely some kind of like brain cancer or something like that. There's a few things you want to ask, right? Does it happen in the back of the head? So this is one of those things that can trigger you into thinking that it's like a tumor or something like a space occupying thing. If it's consistently in the back of the head or in the front of the head as well. If it's present in the morning, if it's present the moment that you wake up, or if it wakes you up in the middle of the night, that's not good. You should definitely get a CT scan and to make sure that it's okay. You might imagine the structural whatever's in there is increasing the ICP, right? Intracranial pressure. What also increases your intracranial pressure is coughing, sneezing, straining. So if those also increase your intracranial pressure, then it'll increase that headache, right? So some things that you'll see. Of course, if they have any abnormal neurologic sign, definitely buy yourself a trip to the CT scanner. Also vomiting too, with a headache, which can be difficult, to be honest, because if you're vomiting, right, you're straining, and even just from that straining, you might have a headache, or maybe you have dehydration because of the vomiting, and the dehydration is causing the headache, right? So you want to try to distinguish that as much as you can. Try to think of other symptoms, but always keep in mind in the back of your head that it could be a tumor. Microcephaly, the definition is listed right here. There's a lot of different causes. A lot of times genetic. Maybe it's kind of destructive insult. It could be from a hypoxic ischemia as well. And these children are very often very developmentally, intellectually disabled. So hydrocephalus. So CSF is always constantly being produced and reabsorbed. So there's some kind of breakdown in this. Either there's too much being produced or not enough being reabsorbed, right? As listed right here. And so you may see the head become enlarged, right? But only if it's acquired after the closure of sutures. If the hydrocephalus was there from the beginning, it'll actually stretch out your head, and it'll actually make your head circumference get bigger than you would have expected otherwise. That's part of the reason why we have to measure head circumference. Commonly associated with myelomeningocele and Arnold-Chiari malformation, Danny-Walker malformation. I don't need you to know what these exactly are, like where the actual malformation is inside, like the structure and all that, but I just need you to know like the names of it. Be able to identify these as things that other syndromes that hydrocephalus is associated with. So there's also communicating and non-communicating hydrocephalus. You should know that non-communicating is the most common among children, right? Some kind of impaired flow. All right, hydrocephalus. When it comes to hydrocephalus, the early and late signs, I think that a lot of this stuff like difficulty holding head are pretty vague, in my opinion. So irritability as well. Bulging fontanelle is definitely what else could it be other than just some kind of increased pressure inside the brain? I think that it's easier to understand the late signs, the sun-setting eyes, especially the apnea spells and the high-pitched cry. So all three of these actually are very classic late signs, right? So if you kind of remember what hydrocephalus can look like and you can identify the late signs, then everything else is an early sign, right? Hopefully that helps you out, because a lot of this stuff is pretty non-specific. The increasing head circumference, split sutures, protrusion of the face, right? Because that pressure is pushing out onto the face, declining level of consciousness. Those are fairly non-specific. But if they have the sun-setting eyes and apneic spells, that's not good. Any kind of high-pitched cry, that is definitely not good. So this, if you want to treat hydrocephalus, a lot of times you'll put in this VP shunt, right? So the blood from the ventricle is going to go through here. You're going to empty it out down through here. And you see how it's kind of attached on at a few different points along the child's body. Then over down here, you just have some extra tube just coiled in, right? Ideally, as the child grows, that coil just straightens out, and then that's all you need, right? But they often need revision. So if any child comes into the emergency room with a headache, then they're going to get what's called a shunt series, X-ray shunt series, where they X-ray every part of this pathway to make sure that it's all working like it should be, in the right place that it should be. So often placed at about 3 to 4 months of age. And the moment that you put it in, you may actually see a decrease in head circumference by a couple of centimeters, but then head growth occurs again. If the head growth completely stops, then that's also a problem too, right? Head growth should occur no sooner than 2 to 4 months after. Neurotube defects, you should just know anencephaly and encephalocele just in general, right? And it's also spina bifida occulta. Obviously, anencephaly is not sustainable with life. Cephalocele is pretty bad too. Spina bifida occulta is actually not too bad, right? You don't even see it. That's why it's called occulta. From the outside, it looks fine, but there's actually a vertebral defect hidden underneath the skin. Spina bifida cystica is where you get your meningocele, where there's meningeal sac, and your myelodysplasia, which has your meningeal sac and a portion of your spinal cord as well. Okay, so you guys have probably heard folic acid and spina bifida all day, every day, so I don't need to go into that. It should make sense that the manifestations are different based on the level of the spine that it's occurring at, right? If it's occurring in the sacrum, that's the lowest part, so you're only going to see symptoms kind of in your ankles and your toes. If it's all the way up in the lumbar, you may see involvement in the hip, and if it's up to the thorax, you may have a complete paralysis of the legs, but also kind of weakness and sensory loss in the trunk and lower body, right? So basically, the higher you get, the more serious it can be, right? And if you're all the way up to the thoracic level, there's a good chance that you also don't have you don't have bladder control or bowel control, unfortunately. So they may have this neurogenic bladder. So a few different clinical manifestations are listed here with their cause, so make sure you understand that, at least in theory. You don't have to memorize every single detail, but you should understand the general way that these manifestations come about. If they have a neurogenic bladder, they'll probably get like a Mitrofanoff procedure to keep to be able to catheter the child easily. Based on how good their catheterization technique is, either the parent doing it or the child themselves once they get old enough to do it themselves, they may not have as many bladder infections, but they're probably going to have some, and most likely a lot, right? There's only so much you can do with the neurogenic bladder. It's going to cause problems, unfortunately. Same thing for stool incontinence. They may also get a surgery for that as well. So myelodysplasia, it's better to have their legs kind of in this position right here, so that you can relieve some of the skin around here. It's not stretched so tight, right? So this position is the best. You're going to monitor for leakage of CSF, which is obviously a bad thing. Do some gentle range of motion exercises so that they're not getting stuck in one place, that their limbs are developing well, and just prepare the parents that they may need multiple surgeries, right? So they may need to get tested for get tested frequently for urinary tract infections, like I had said. Structural defects, craniosystosis, and positional plagiocephaly. I feel like this picture pretty much sums it up. So if you have questions, just kind of read your book. This is pretty self-explanatory. Just kind of have to know that there are malformations of the skull as it's developing. And there we go. All right, so neonatal abstinence syndrome. Neonatal abstinence syndrome is when the mother is using some kind of illicit substance, right? And initial signs has this really high-pitched crying along with this irritability. So the irritability is going to mean they're going to cry a lot. And it's going to be this high-pitched crying. So if you spend any time in a NICU around a baby with neonatal abstinence syndrome, it's very likely that you'll hear this high-pitched cry quite a bit. You will see them do a urine drug screening on the baby, but the meconium screening is really where it's at. There's several. It can detect illicit drug use even months before birth, right? Which is way better than a urine drug screen on an infant, which only measures a couple days or like a few hours even. Very unreliable, but the meconium screening is very, very good. Breastfeeding is encouraged. There's only a minimal amount of drugs that can cross over into the milk, and very likely this child is going to be getting treated with something like methadone anyway, right? So the little bit of extra opiate that comes through the breast milk will not harm the child, and it may even help. Neurofibromatosis. It may sound like some kind of skin disorder, but like a musculoskeletal disorder, but the origin of it has to do with the nervous system. That's why it's in the nervous system chapter. And you may see these like cafe au lait spots, but there's a lot of different symptoms that that you might see. Body image is a very, very important consideration for children with neurofibromatosis, as you might imagine. Cerebral palsy. So cerebral palsy is some kind of syndrome of movement and posture development caused by a lesion in the brain. So this doesn't have some kind of musculoskeletal etiology, has to do with the nervous system. It's also non-progressive, which can be kind of weird because the symptoms will change from age to age, but the lesion itself isn't getting worse. It's staying constant. It's just that the symptoms change and it may look worse, but the syndrome actually doesn't worsen over time. A lot of different risk factors, a lot of different things that may cause cerebral palsy. There's a lot of different types of cerebral palsy that may be caused as well. So that doesn't help to confuse it any less. But definitely you'll see this abnormal muscle tone, lack of coordination. You might see like contractures and stuff like that. And difficulty feeding, especially early on, is very, very, it's something that you may have to deal with. The spastic cerebral palsy is the most common type. Can lead to contractures, abnormal spine curvatures, and we already talked about the persistent common newborn reflex, right? If you see it at an age past when it should have gone away, then you want to think cerebral palsy. So there are definitely medications that you can use, especially if there are seizures along with it, spasms along with it, and GI side effects. But there's nothing you can do to undo that lesion in their brain, right? Unfortunately, prognosis depends a lot on the motor disability. Of course, the level, right? Some people just have really, really bad cerebral palsy. Some people have a limited form of it. Early intervention is always best, and getting as many people involved is always good, right? A good primary doctor, a good physical therapist, occupational therapist, people to help train the mothers in terms of how to get them as mobile as possible, getting them enough resources to do all these things. As you can see in this picture to the right, this kid obviously has some like gear on him, right? That gear, some of that stuff is very expensive, right? You look at it, it may not seem expensive, but it is, right? And there's a lot of different things you can adjust, right? The length of different things of like all these different straps, all these little buckles, all these little twists and turns that you can do. A lot of that adjustment needs a lot of work, right? Thankfully most parents are pretty good about cerebral palsy. They know exactly how to position them, and you don't feel bad at all by asking them about like what's the most comfortable position for them. If anything, they'll respect the fact that you are asking them, and they'll give you a lot of great advice. Remember that when you come into the room, do not go immediately to the parents. I can't tell you how many times I've seen nurses, they'll instinctively, they see someone with cerebral palsy, they won't address them, instead they'll address the parent. Always address the child first, and by according to their developmental age, not according to how they look, right? A lot of kids look delayed on first impression because we're used to seeing people who like look like that, right? Just make these prejudgment calls. They seem delayed to us on first glance, but they're actually neurologically intact, right? It's very disrespectful to them to talk down to them because of the way that they appear. So if anything, overshoot, to speak too mature for them, and then slowly adjust down as needed as you start taking cues from the parents as well. Traumatic brain injury, there are different mechanisms of injury based on age. Of course, 0 to 2 year olds is pretty self-explanatory, just falling from stuff, or just falling just generally right onto the floor. Once you're in your teenage years, then you can start like fighting each other. You get playing a lot more aggressive sports and driving cars, right? So these are those kind of shoot to the top of the list. This slide should all be reviewed from adult stuff. There's a primary injury, the actual cells hitting against the side of the brain or whatever have you. Then the secondary injury, as the brain starts repairing itself and all the inflammation that happens as a result, that causes secondary injury. So make sure you understand the difference between mild brain injury and moderate brain injury. Like, you really need to know concussion really well, right? Severe brain injury will be fairly obvious when you see it. I mean, they're going to have a GCS score of less than 8. They'll be in a coma. They may be having a seizure. and they'll have these really increased intracranial pressure and all the signs that result from that, right? So that's pretty easy to identify. But a lot of people confuse these two right here, between a mild brain injury and concussion. Between mild and moderate brain injury, right? Any kind of post-traumatic amnesia, any kind of loss of consciousness, automatically pretty much kicks you over to moderate brain injury. So there are differences in the way that people draw these different boundaries, and there's a lot of controversy about that, but just go off of the tables on the slides as far as our test goes. But just be aware that different people will draw a line differently. So it's not super firm, but in terms of what constitutes a mild and a moderate, but yeah, there you go. All right, when it comes to intracranial hemorrhages, subdural hematoma is something that you definitely need to know, right? Something that happens in kids, very, very common in infants less than 1 year old. Or not very, very common, but it's very dangerous for children under 1 year old because they can get it. And so you'll have these symptoms that gradually change over time, and they may start vomiting. So if they have these two signs right here, then that's pretty much a instant trip to the CT scan, right? Of course, if they have any of these things, then that's really bad, right? Eye deviation, you can imagine how these sound just terrible. So honestly, I think most people will have no trouble identifying these as signs of brain hemorrhages, intracranial hemorrhage, but maybe not so much this gradual change in LOC and the vomiting, right? So make sure you can understand that. Epidural hematoma is one of those things where it's very easy to detect because it is, as opposed to subdural hematoma, which is the result of venous blood, which is why it takes a long time to fill up. Epidural hematomas, your epidural area is perfused by arterial blood. So arteries are pushing blood into your brain a lot faster, and you have very, very rapid deterioration. And you'll know it right away, right? If they had a head injury and they're having rapid deterioration, that's not good. That's probably epidural hematoma. Diffuse axonal injury has some kind of rapid acceleration, deceleration, right? This is important for kids because motor vehicle collision is a big deal in kids, and shaken child syndrome is a huge deal in little infants, right? So basically you get like immediate loss of consciousness and get this really, really long LOC, over 6 hours. This is insane. This is a long time to have loss of consciousness. Anything like that is a severe, severe problem. Any kind of abnormal movements, posturing, seizures, of course. So we have to be able to identify this as like a big deal, and we have to know that this is diffuse axonal injury because we have to make sure that it fits the description, right? If the parents say that the child just like fell from a bench onto the floor, there's no way they're going to get a diffuse axonal injury from that. It requires a huge amount of force. It has to be really rapid acceleration, deceleration. It can't be from a simple fall. So here's a few different things that might trigger you into considering abuse cases. Just listed right there for you. Shaken baby syndrome, a few extra things to look at. Even throwing an infant onto a mattress can cause brain damage, and there are parents who've done that. Thankfully, I have not seen that myself. Hopefully, I haven't. But as far as I know, I've never heard of that being done, but it has been done. All right, so do your ABCs, of course. I had talked about vasodilation and the hypercapnia, and how that works, and how hyperventilation can cause vasoconstriction. So if you don't understand that, then kind of review that or just ask me. Of course, you may want to do a ventriculostomy. You won't always do that. You won't always give the mannitol, but if it's increased intracranial pressure, you're probably going to give mannitol, maybe 3% saline. But from what I've heard, it's mainly mannitol, or that's the first line. All right, positioning obviously is very important. It's a very nurse-specific thing. We want to make the neck straight and let the blood drain down from the brain into the body. Many have long-term problems, as you might imagine, right? With all sorts of like mental things. Prevention of future events is very, very important, especially for concussion, right? So concussion, all those symptoms that we talked about, it can last up to 7 days, right? And parents might say like, oh, okay, we got a CT scan and there's nothing, there's no bleed shown, right? So it's fine. But it's very important to insist to parents like, look, their brain was damaged, right? It was like actual brain damage, and they will have symptoms for several days, right? The last thing we want them to do is get another injury on top of that one, right? And that's one of the ways that a lot of these sports injuries are happening, is because these concussions are just so bad, and they happen very close to each other. They don't get the time to recover the way that they should. Even sometimes, even 7 to 10 days is not enough. They need extra time to make sure that they're 100% cognitively ready to go back. Make sure you understand the signs and symptoms of concussion. That is very, very important, because it's very common thing that we see, right? So we have to be able to identify this for sure. So it can be a lot of it is really, really non-specific, right? They might have like sensitivity to noise. They may have like this nausea, maybe vomiting, right? So vomiting, you may want to give them instructions on how frequently they can vomit before you have to bring them back to the emergency room. And maybe we need to do another CT scan just to make sure there's not like a subdural hematoma going on. But if they're feeling like foggy or sluggish, confused about things, that might sound like it's really, really bad. But after concussion, after concussion, that can be this is a normal part of the healing process. So how to increase just recovery from that? You have to limit cognitive activities. In the olden days, they used to recommend that you totally cut out, or that you keep people awake after concussions, right? That is no longer the case. We found that it actually cuts down their recovery, because we need to limit their cognitive activity as much as possible. So I already talked about how they can have a second injury on top of their first concussion. Scalp injuries, skull fractures are pretty simple to understand. So spinal cord injuries, children are at extra risk for, so we do need to know about that, right? And some of it's actually very simple to think about. They have a very large head. They have underdeveloped neck muscles, right? So that joint right here where their neck is, that is very vulnerable to any kind of like sudden move of the head. And that's why when we're holding the kid, you have to be very, very careful about cradling their neck, right? So yeah. When it comes to hypoxic ischemic brain injury, I just wanted to show the general process by which a child may be trapped in what is a very small amount of water. So you might look at a small amount of water, like it looks like a puddle, and you're like, oh, no kid can ever drown in there. And this may seem like very like this whole description right here might sound like crazy talk, like some kind of really rare situation, but it actually can happen. And it might not be as rare as you might think, because children are just weird like that, right? They do things like panicking. They're not like us, and their panicking can cause struggling, and it causes more problems right here, where you swallow water, then you vomit it, then you aspirate it, and then you pretty much drown in the vomited water that you aspirated. So very, very important to educate people not to leave children around bathtubs. I don't care how little water there is, you do not leave them around any amount of it unattended. Alright, submersion victims must be observed in the hospital. There's a lot of secondary damage that can happen. You might have heard of like dry drowning and stuff like that, so we may want to monitor those people and keep them overnight in the hospital. Of course, if they're taking alcohol and drugs, then they're at extra risk of drowning. Even if they're not as young as the child described in this scenario, they may be just too hopped up on alcohol and drugs to know any better. So, all right, thank you for bearing with me as I try to barrel through these these lectures.